Assalamu alaikum everyone, and good afternoon. So today I'm delighted to introduce my dear colleague Dr. Hamad AlSulaiman. He's a member in our department and he's supervising our fellowship program in ocular plastics. He had so many interesting talks and I'm sure today is one of them. We're excited to hear your presentation entitled Targeted Therapy for Periocular Adnexal Neoplasm. And the mic is yours.
Good afternoon, everyone. It's good to be back physically presenting in the ground rounds again. I know you're fed up with oculoplastic presentations after last week, so I tried to make this one short, so it's only 70 slides and some more. I'll go through them as quickly as possible. So the talk will be about targeted therapy in periocular neoplasm with specific focus on one of them. We'll talk briefly about all targeted therapies. We'll talk about skin cancers, and then we'll talk specifically about the Hedgehog pathway inhibitors. As you all know, in the last 2 decades, there was huge advances in oncology and rheumatology with regards to treatment, especially those agents targeted directly to specific molecules. This is in contrast to the previous chemotherapy and anti-inflammatory medication, which was, they were non-specific, and they targeted cells that have high mitotic activity. We have 2 main types that are in use usually. Those are the monoclonal antibodies. Usually they end up with the 3 letters MAP, M-A-P, and the small molecule inhibitor ending in E-I-P or IP. The monoclonal antibodies are usually binding to antigens, and usually those antigens are on the cell surface. And the small molecule inhibitors usually inhibit by blocking metabolic or enzymatic step in target cells. So you can see here a list of monoclonal antibodies used in periocular neoplasm. You have rituximab or anti-CD20 used in distal lymphoma, also brentuximab or anti-CD30 used in lymphoma. You have the epithelial growth factor receptor inhibitors used in squamous cell carcinoma, including cetuximab and panitumumab. And you have also the checkpoint inhibitors, which are the PD-1 inhibitors and the CTLA-4 inhibitors. The cemiplimab here is used for squamous cell carcinoma, and the rest are used for melanoma, skin melanoma. And in regards to the small molecule inhibitors, you have the vismodegib and the sonidegib in the Hedgehog pathway inhibitors. They are used in basal cell carcinomas. And you have also the epithelial growth factor receptor tyrosine kinase inhibitors used in squamous cell carcinoma. And there are other small molecule inhibitors used in less seen tumors, like inflammatory myofibroblastic tumor and soft tissue sarcoma. Okay, what about skin cancer? As you all know, it's the most common form of malignancy in the world. A total of 3.5 million cases are reported in the United States of non-melanoma skin cancer each year. 80% of these cancers are basal cell carcinoma. The prevalence of basal cell carcinoma tend to be much higher in patients with fair-skinned individuals with high cumulative ultraviolet susceptibility factors such as light eyes, light hair, and inability to tan. And the incidence increased depending on the exposure to UV radiation. And for that reason, intense solar UVB radiation is the most important environmental risk factor for the development of non-melanoma skin cancer. The lifetime risk for basal cell carcinoma ranges from 33 to 39% in Caucasian men and 23 to 28 in Caucasian women. So, what is the story behind the Hedgehog pathway inhibitors? The Hedgehog pathway play a key role in the embryonic development of stem cells, or embryonic development and stem cell programs. They also play a role in cell proliferation and survival through regulation of gene expression. So it has a role in cell regulation and multiplication. And for that reason, the regulation of this pathway is a key driver of basal cell carcinoma. How does it work? We have the BATCH1 protein, which is a membrane protein located on the cell surface, acts as a repressor of the cascade by inhibiting the smoothened or SMO protein. Once this is inhibited, the downregulation or the cascade that leads to transcription of several factors that lead to multiplication of cells is inhibited. What happens is that the Hedgehog pathway or the Hedgehog ligand will attach to the BATCH1 protein. This will cause repression of the BATCH1 gene and activation of the SMO protein and also activation of the cascade. So BATCH1 is or the smoothen gene is a pro-oncogen. Smoothen protein is a pro-oncogen. What happened with basal cell carcinoma, that majority of cases, they have a loss of function mutation in the BATCH1 gene, preventing repression of the Hedgehog cascade. Others have gain of function mutation in the SMO gene, leading to overactivation of this pathway. So, having said that, now we'll talk about vismodegib. This is an oral medication that was FDA approved in 2012 for the treatment of basal cell carcinoma. How it works, it suppresses the Hedgehog pathway by directly inhibiting the SMO, bypassing the need for normal functioning BATCH1 protein. The indications by the FDA are metastatic basal cell carcinoma, locally advanced basal cell carcinoma that has recurred following surgery, patients who are not candidate for surgery, or patients who are not candidate for radiation treatment. These three studies, phase 2 studies, played a role in the FDA approval of this medication. We'll talk about this one, then we'll compare it to the rest here. The Evans trial was published in 2012. It was a phase 2, multi-center international, single-arm, non-randomized study with 2 cohorts. The first one was patients with metastatic basal carcinoma, and the second are patients with locally advanced basal cell carcinoma. In this trial, all patients received 100 milligram of oral vismodegib daily until disease progression or intolerable toxicity. The primary endpoint was the independently assessed objective response rate. And for the locally advanced basal cell carcinoma, they defined decrease in 30% or more, or externally visible or radiographic dimensions. 33 patients were in the metastatic basal cell carcinoma, and 63 patients were in the locally advanced basal cell carcinoma. In the 33 patients with metastatic basal cell carcinoma, the response rate was 30% only. All of them were partial response. In the patients, second group, where we have 63 patients, the response rate was 43 patients, 43%, and 21% of those had a complete response rate. Adverse events were common. The most adverse events were grade 1 or 2. They were muscle spasm, alopecia, dysgeusia, decrease in weight. Only 12% had an adverse event that led to the discontinuation of the treatment. And most common reason was the muscle spasm reported in 2 patients. Serious adverse events were reported in 25% of patients. 7 deaths were reported in this study. However, these events, they didn't have any definitive pattern. These patients had clinically significant risk factor and coexisting conditions at the baseline. Here are some examples of how the medication works clinically. So this is patient at baseline, and you can see here at week 8 and then at week 20. Here's another example, baseline at week 24, baseline in week 24, and again baseline in week 24. Fast forward 5 years to 2017, they published their update on this trial. It was now 39 months follow-up, only 8 patients were in the study. And we had only now 69 patients in the survival follow-up. The objective response rate went up in the metastatic basal cell carcinoma from 30% to 48.5%. Again, all of them were partial responders. And in the locally advanced basal cell carcinoma, the group, the response went up to 60.3%. 20 patients had complete response, and 18 patients had partial response. When they looked at the subgroups, including aggressive histologic subtypes, they were comparable. And the median duration for response was 14.8 months only in metastatic basal cell carcinoma, and it was 26.2 in the locally advanced group. The adverse event remained consistent with the clinical experience. However, they noticed that with increased duration of treatment, more side effects will be visible. So how does this compare to the other studies? The other study, the EAS, the second one, had 120 patients included, and the STV, which is the last one, had 499 patients included. So if you look at the objective response rate in the metastatic group, it ranged from 30.8% to 48%, and the locally advanced basal cell carcinoma, it ranged from 46.4% up to 66.7%. One point to mention, in the STV trial, more than 98% of patients had side effects. So this is all good, but how does this translate into periocular and orbital basal cell carcinoma? In the next few slides, I will review some of the studies that were done with the primary treatment with vismodegib in orbital and periocular basal cell carcinoma. And then we'll talk about other ways of treatment. The first one was published in 2013 by Gill and his group. It was a prospective case series, 7 patients not amenable to surgical radiation. 4 of those patients had orbital involvement. The same protocol was given, once daily, 150, until maximum clinical response or tumor progression or intolerable side effect. The primary endpoint was the reduction in the lesion size, measured as percentage change in the externally visible dimension. Notice here that the mean duration of treatment is only 11 weeks, which is so short. And the mean duration of follow-up was 7 months, which is again short for basal cell carcinoma. As you can see, 29% had complete response, 29% had more than 80% partial response, and 29% only had less than 35% partial clinical regression. And only 1 patient, or 14%, had progressed. So you cannot make a judgment, clear judgment from this study. Let's look to the other one, or at the other one. They had, it was a retrospective study done by Oscar and his group, included 12 patients. Median follow-up time was 12.5 months, with a range between 7 and 53 months, which is much better than the previous one. The median duration of treatment was 11.5 months, and this resembles the previous trials, phase 2 trials, more. The overall response rate for the locally advanced non-metastatic group was 86%. For locally advanced but metastatic group was only 33%. So this also correlates with the previous study. They included 2 patients with basal nevus syndrome. All of them responded well. 3 of the 12 patients had complete response with follow-up, and 6 patients had partial response with a median follow-up of 9 months. And 2 of the 12 patients developed disease progression during the active treatment. They noted that after initial clinical response or stabilization lasting at least 6 months, patient also can progress afterward. All 5 patients with T3 basal cell carcinoma who would have required orbital exenteration for their tumor avoided orbital exenteration. So this is a point to keep in mind when we review the next few slides. This is another study by Demercy. It was a retrospective study, 8 patients, 6 of them had biopsy-proven orbital basal cell carcinoma, and 2 had extensive periocular basal cell carcinoma. And 1 of the 2 had basal nevus syndrome. Same protocol. The 6 patients received vismodegib as the only treatment or primary treatment. 1 patient had it as an off-label neoadjuvant treatment before surgery, and 1 had it after surgery as an adjuvant treatment. 50% showed partial response, 50% showed complete response after median follow-up of 13 months. They noted here that the best response was obtained in the 2 patients whom vismodegib was used as an off-label neoadjuvant or adjuvant treatment. Again, the side effects were correlated with the previous phase 2 trials. They mentioned that they had to give some patients 1 to 2 week drug holiday so they can tolerate the medication better. This is another study. They included 15 patients, as done by Wong. It was a prospective case series. 10 patients had an orbital involvement. Mean treatment duration also was 13 months, which is good. And you can note here that they have a long follow-up of 3 years. 10 patients had a complete response rate, which is 67%. 20% had partial response, and 13% had progressive disease following the initial partial response. Also note here that they mentioned that 1 of the patients who had partial response allowed subsequent surgical resection with clear margin. So they concluded that it is an effective treatment for periocular and orbital basal cell carcinoma with orbital salvage of patients who otherwise would have required exenteration. There is a neoadjuvant role for vismodegib, but further studies are required. So as you noted from the previous few studies, they all mentioned that neoadjuvant treatment, or they hinted that neoadjuvant treatment can play a role in treatment of basal cell carcinoma. Another study by Moscovich, they included a good number of patients, 21 patients with a median duration of treatment, 9 months, median follow-up 26 months, which is a good follow-up duration. And after treatment cessation, they followed the patient for at least 17 months, or a median duration of 7 months. They noted that there is a complete response in 10 patients, 48%, partial in 10, and stable in 1. However, 5 patients maintained the complete response at 6 months, yet 3 patients who stopped treatment had recurrence 8 months later. So, having looked at these studies, I thought about the role of neoadjuvant treatment and what is there in the literature in this regard. It's true that it's an off-label treatment, but it seems like an attractive option for treatment. So the first study was done by Sagif in 2018. It was a retrospective interventional study. They included 8 patients. All were with T4 periocular basal cell carcinoma. The indication for the neoadjuvant treatment were unresectable tumor in 1 patient, attempt to avoid orbital exenteration 6 patients, and an attempt to avoid disfiguring facial surgery in 1 patient. The median duration of treatment is 14 months, and all patients underwent an eye-sparing surgery following neoadjuvant vismodegib, and all final surgical margins were negative of the tumor. They noted that 5 patients had a complete response to vismodegib with no microscopic residual of basal cell carcinoma found during surgery, which is around 62.5%. 3 patients had significant partial response with residual tumor found on pathology. Of note that therapy was electively stopped in 6 patients after observing a desired clinical response at a median follow-up of 5 days prior to surgery. In the 2 other patients, Vismodegib was stopped due to intolerable side effects. They said that at least at last follow-up, a mean of 18 months, which with a range of 6 to 43 months after surgery, all patients were of Vismodegib and alive without evidence of the disease. Another study by Gonzalez also looked at the neoadjuvant role of Vismodegib. They included 8 patients with locally advanced disease with a median follow-up of 4.4 months. How they did it, they usually started the treatment until reaching maximum clinical response. And afterwards, they gave the patient 1 or 2 extra months of Vismodegib before surgery. Usually, the maximum clinical response was achieved with a mean period of 4.8 months, with a range between 4 and 6 months. 1 patient progressed and ended up with exenteration. 1 patient refused surgery, and he was disease-free after 5 months of follow-up, and 6 patients underwent excision. 5 out of the 6 complete histological response. It was not tumor. And 1 patient had a residual tumor in the histopathology. All patients are disease-free after a median follow-up of 14.4 months. The author believed that there is a clear role for Vismodegib as a neoadjuvant treatment in locally advanced basal cell carcinoma, even in operable cases. This is an example of 1 patient with advanced basal cell carcinoma involving the lower eyelid. And you can see here, after 1 month only of treatment. And you can see here the side effect that came or became visible at 10 months of treatment. You can see the loss of flashes and the loss of eyebrow. Then they underwent surgery. This, with the black arrows, showed residual basal cell carcinoma. This one was negative for basal cell carcinoma. And this is his look or his final outcome after surgery. This is another example of patient with basal cell carcinoma involving the anterior orbit. Here you can see him after treatment, here after excision and reconstruction. Another study was done in Australia. They included 8 Caucasian patients with locally advanced basal cell carcinoma. Median treatment duration was 6 months again, and the interval to surgery was 5.4 months. The mean follow-up was 13.4 months, plus minus 5.2. Again, treatment usually was given until maximum clinical response or intolerance to medication. So for the clinical response, it was partial in only 6 patients and complete response in 2. 2 cases showed squamous cell differentiation, which is noted in several studies. And 1 study also mentioned that there was emergence of squamous cell carcinoma, keratoconthoma type, or well-differentiated type. They noted in this study that the maximum diameter of the tumor with surrounding 3 millimeter margin, simulating the intended surgery at the beginning, was around 27 millimeter plus minus 8 millimeters. And after treatment, it went down to 19 millimeter plus minus 8. Here is an example of a patient. This is the simulated intended surgical margin before treatment. Here are the MAC biopsies that were taken after treatment, and here after excision of the tumor, with reconstruction with the final outcome in the last picture. They concluded that neoadjuvant treatment with periocular basal cell carcinoma has a mixed clinical and histological response. The final surgical excision achieved a clear margin in all patients, no recurrence at mean follow-up duration of 13 months. They recommended to proceed to definitive surgical intervention as soon as possible following completion of plasmodic treatment to minimize the recurrence within this window. So, neoadjuvant treatment seems like an attractive option, should be further explored. They did a study about the preservation of the organ and visual function. So if this is our main outcome, does it work or not? Most of us want to avoid orbital exenteration for patients with advanced basal cell carcinoma. This study was published, I think, 2020 or 2021. They called it BISORB trial, or Plasmodic for preservation of visual function patient with advanced periocular basal cell carcinoma by Kahan and his group. It was an open label, non-randomized, phase 4 trial. They included patients with orbital or extensive periocular basal cell carcinoma. They wanted to assess the visual function in context of invasive periorbital lacrimal disease. They made a visual assessment weighted score to utilize in this study. It contains 8 items that we will go through in the coming slides. They made a score of 21 in this VAUS score or more to be successful score signifying low preservation in these patients. And again, tumor response was evaluated using the standard response evaluation criteria and solid tumor guideline. This is the VAUS score. You can see here, if the patient has his globe at the end of treatment, he scores 20 immediately. And here are other what do you call it? Conditions that they included: visual acuity, fusion, diplopia, and the lacrimal system function. Each one has a different score here. They used the same protocol, 150 milligram plasmodium orally once, and they landed for 12 months. Or if the disease progressed, or there was an unacceptable toxicity, or a patient couldn't tolerate the medication, then they will advise for surgical excision. They included 34 patients, 19 of which presented with lesion whose complete excision with clear margin would have likely required exenteration, and 15 patients would have qualified for a globe sparing surgery but resulting in loss of lacrimal drainage system or extraocular motility muscles. The median treatment duration was 8.7 months. 27 patients, or almost 80% of patients, elected to undergo excision prior to completion of 1 year course of treatment due to poor tolerance of plasmodium. One patient died prior to completing this study. All patients maintained a VAUS score of more than 21 at 12 months or post-op. You can see here, this is at the beginning of screening, and here at the end of the treatment. And again, for the VA, only one patient lost some lines compared to baseline. Diplopia, they actually improved. Tearing, they actually also improved here. 56% of patients achieved complete response. 29% of patients had partial response, and 6% had a stable disease, and none of the patients had a progressive disease. So the surgical specimen from the 27 patients who elected to undergo excision underwent histological evaluation. 67% achieved complete histological clearance, 22% had residual disease but with a clear margin, and 11% had disease extending to the surgical margin. So taken together, you have 25 patients or 37% patients were able to achieve complete response rate. Here's an example of patient at the beginning and 3 months after the treatment. Another example of patients with basal cell carcinoma, and after 9 months after treatment, it's a huge one here with 6 months of treatment. Another patient involving the medial canthus, and after 9 months of treatment, there's a small tumor here, and at 6 months of treatment, and here also tumor involving most of the lower eyelid, and 9 months after the treatment. They concluded that it is an effective treatment in protecting the eye and the visual function, either alone or more commonly as a neoadjuvant therapy. And they advised that or recommended that such treatment should be considered for basal cell carcinoma that might otherwise require orbital concentration or surgery that cause significant loss of function. There is a note to keep in mind here. They didn't follow the patient for a long time, and none of their outcome measures were to see if there is recurrence afterwards. So the idea here, as the primary treatment, can you save the globe or not? So after reading all these studies, I wrote some notes to keep in mind. It is an effective treatment. Off-label neoadjuvant vismodegib is an attractive option to consider. Globe-sparing options are now available. Discuss these options with your patient. Recurrence and resistance can occur despite either during treatment or after you stop the treatment. Side effects are common. Most of them will be tolerated by the patient. However, on the long run, some of them will discontinue the treatment. So you need to have a plan B. Be watchful of liver toxicity. Some reports indicated that vismodegib caused liver toxicity, and whether it can or whether it causes breakthrough squamous cell carcinoma is something that we need to watch for in the future. Thank you.
Thank you very much for the comprehensive review. I thought 70 slides would take more. Any questions to Dr. Hamad?
حاضر دكتور.
Thank you, Hamad, for a really interesting update. I have two questions. First is, they seem to be effective in 60% of the patients. However, they don't seem to be available widely. We've had few patients, we had difficulty in acquiring these medications. Is it cost or is it the experimental? My other question is, can you use them after radiotherapy and cryotherapy?
I didn't pass through any case that was used after radio cryotherapy, and it's not in their indication in the FDA approval, but I assume it might be used. Why not? There is no clear reason to prevent us from using it. Why it's not available, that's a question I don't have the answer to. It's not cheap, it's expensive. It's not an experimental drug. It is approved, used in the United States and Europe. It should be available.
Because it's not available at King Faisal. We tried, didn't we?
Do you have King Faisal?
Well, the
You have it
issue
at
is, maybe I answer this question.
Okay, thanks so much, Rich.
The issue they have difficulty even in the US because this medicine is expensive. And most of the patients, they need this medicine, they are uninsured. So because they reach to that stage where this medicine is, it's really, because they don't have insurance. If they have insurance, they will not reach this stage. And the problem is this medicine in the US used to be provided by some agencies, and they cannot tolerate the cost of the medicine. Even in one stage, the company decided to stop making this medicine because of the cost, and people are using it, they're not having the money to pay for it because most of them are uninsured.
I was surprised King Faisal doesn't have it.
Yeah.
King Faisal really buys expensive medication.
Actually available.
And we
It's not
tried.
available yet.
No, it's not. That's why I'm just
Yeah, this is even the US at one stage. I remember attending the Cyprus meeting in 2017. They were thinking, the company thinking of stopping the medicine. because of the cost is high and not many people are really offering this treatment or affording this treatment.
And you mentioned depth, right? So was it related directly to the medication or to the status of the patient?
There was no clear definitive pattern when it comes to that with this medication, at least yet.
Any other question?
Thank you, Dr. Hamad, for this wonderful presentation. I know we don't have a lot of experience in using these medications, but it's really a good review, for what's available in the literature. I remember I came across 5-FU and itraconozoles being used also for basal cell carcinomas a long time ago. We have an interest in using 5-FU as a chemo reduction for OSSN, but I remember that it was approved also for some of the skin tumors as well.
Yeah. I didn't review the literature on this one, but also other topical medications are used for basal cell carcinoma.
It was an injection, actually.
No, like imiquimod also is used for basal cell carcinoma. 5-FU, I think it is used, but I don't have enough experience or review on this.
For basal cell carcinoma, they're using other medicine because more responsive than 5-FU.
Yeah, I see.
Any other questions?
Well, it's interesting now is the era of treating tumors with medication, and more medicines are coming. Maybe 2 years ago, they approved there's a report of using effective medication for melanoma, cutaneous melanoma, that's melting it out. And in the future, we'll see more and more, because this is where really the treatment should be directed, is preserving tissue with medication. He gave all the list for this. So this is the area that we need to afford more, and we really need to offer the patient the treatment, even if it's not available here, to give them the option. Sometimes they can get support from higher authority here in the kingdom to travel for, because I have one patient had really the treatment done in the US and came back. It's expensive medication, but he was able to get it done. So it's one of that we need to discuss with the patient.
Anything that saves the globe or avoid exenteration is an option that we need to seek and always provide.
And we have good examples of using, for example, capillary hemangioma. Now we're treating it with oral medication, and maybe with some success we have lymphangioma treated with medication. So more and more we're having more medicine. And the good thing is about this migrated, maybe after a while it will be available more, because the patency will be done. So the new companies will make similar molecules that will be cheaper, especially in the rest of the world, not in the US.
Now this one is also approved for the treatment of basal cell carcinoma. And from what I reviewed, there are several medications that doesn't have names, are still under studies.
Thank you for presenting a really interesting topic. That is the hot topic now in oncology.
It will be redundant soon.
Huh?
It will be redundant as surgeons soon.
No, well, still there's some work to be done, so don't worry. Well, that's a big question came out when the thyroid eye disease get treated with medication. But it's not like the 100% guaranteed treatment. There is still some room for surgery.
Thank you, Hamad.
Thank you, Hamad.
Excellent.
Thank you very much. We really appreciate it. It was so comprehensive, so organized, and it's so clear. The use of right that we think first. Thank you very much.
Thank you.